Good afternoon, everyone. Thank you so much for joining us today on this very, very busy news day, this very busy news week, month. Um, Hello, my name is Joe Burns. I'm the beat leader on health policy and health insurance for the Association of Healthcare Journalists. Our webinar today is one in a series for health journalists seeking story ideas and resources they can use in their work. And today's webinar is about finding and sharing hospital prices with your audience. As many of you know, in 2001, the Federal Department of Health and Human Services required all hospitals to post the prices they charge patients for services. Today, we'll focus on hospitals. Well, HHS also required insurers, but today we're going to focus on hospitals because many, but not all, have complied with that rule. And while the rule went into effect 4 years ago, finding the actual prices that hospitals charge for 300 non-urgent, also called shoppable services is challenging, if not impossible, for most consumers, and it's a struggle for journalists as well. So if hospitals have not complied fully, journalists, all of us, health care journalists, health reporters, have an opportunity to empower consumers by finding and publishing hospital price information. And that sounds simple enough, but as we'll see today, and as many of you know from your work, finding actual prices is not easy. So our goal today is to show you how to gather price information from hospitals and compare prices among multiple hospitals. Our speakers today will be Meg Wingeter, who covers healthcare for the Denver Post and has written on this subject for the Post in the past few months. Patricia Kalmar, the Senior Director for Healthcare Campaigns at PIRG, the Public Interest Research Group, and Kiana Moore, a consultant who works with employer coalitions nationwide and others to help them get the hospital price data they need to negotiate effectively with hospitals. This webinar is one in a series that is supported by the Peterson Milbank Program on Sustainable Healthcare Costs. In this series, we've covered the affordability of healthcare by diving into healthcare cost drivers and looking at solutions to help journalists understand how states, employers, and others can promote affordable healthcare and be able to tell these stories in the context of their state and local communities. So today, we'll begin with Meg Wingeter, and I just want to, I'm going to ask everyone to please post your questions in the Q&A and not in the chat, and we will get to them after the speakers have spoken. So we'll begin with Meg in beautiful Denver, Colorado. Meg, go right ahead, please.
Thanks for having me on. I apologize if I'm a little bit scatterbrained. I just got back from maternity leave last week, so I'm still getting back into things. But I'm going to go over some basic story types that you can do on hospital price transparency. Um, Basically, the ones I have done are your hospitals complying, covering what your state is doing in terms of using that price data, and giving people kind of a how-to of what they'll pay. I'll also talk a little bit about using the price data to do stories based on comparisons, though that one is considerably more challenging. The other panelists are going to give you a lot more detail on the rules, but just the basics, so we're all working from the same place. So the Centers for Medicare and Medicaid Services require hospitals to post a machine-readable file, basically a format a computer can search, so not something like a JPEG, with all of their prices, and either a list of shoppable services, things people can schedule, non-emergency services, or an estimating tool. In Colorado, most of our hospitals opted for the tool, which is probably a bit easier for the consumer, maybe not as great for the journalists, because if you want to look at multiple items or services, you have to specifically search each one, and it's not always going to be intuitive how they are going to categorize those things. And CMS can fine hospitals if they don't post these things. They haven't done that very often, so if a hospital gets fined in your area, that's an outlier and that's a story itself. But assuming that no one has gotten fined in your area, the next question, kind of the logical place to start for a story, is looking at, are they complying? Groups like Patient Rights Advocate .org put out reports which are pretty easy to cover. There is a bit of a he said, she said element with your local hospitals or your state hospital association, because they are going to disagree with the report if it shows that they are not complying. For example, the Colorado Hospital Association rightly pointed out that CMS makes the ultimate determination and they haven't opted to fine anyone in our state. But as I noted, not issuing a fine doesn't equal a ringing endorsement of transparency. You also, CMS has a tool to check hospital filings if you wanted to do some of this on your own, but it just looks at format. So if if it shows that your hospital is not in compliance, they're not in compliance. But if they pass that formatting tool, they still could be falling short on other levels. And it's also worth noting nobody is checking the accuracy of this data. They're just checking that it's there. So that is something reporters could do. We could spot check, look up prices, and then call hospitals and insurers to see if they're accurate, but that would be a big undertaking. Another way you can report on this data is to see what your state is doing with it. In Colorado, it's been a major priority for our governor and also for the legislature, so there's quite a lot to report on. The state has its own disclosure requirements, which then allows it to produce its own reports. They're a bit duplicative of what the federal government has, but as we've seen this week, federal rules can change. So it's worth noting if your state is doing that on its own. You could also look at what your state or local public employee health plans are doing. In Colorado, they are basically offering carrots, incentives to employees when they have when they need something that could be scheduled at multiple hospitals, like a joint replacement, to choose hospitals that are cheaper and, at least according to Healthcare Blue Book, offer better outcomes. Some employer groups are also doing something similar, which you could look into that, because of course employers have a very real desire to keep health care costs down, and one of the ways they can do that is trying to steer their people in a certain direction. You could also look for, in Colorado, the state has two new tools for looking up healthcare prices. So you could see if your state is doing that, and also if they've passed any laws around price transparency. Last year, Colorado passed one labeling it a deceptive trade practice if a hospital doesn't post its prices, meaning that the state attorney general can get involved, though so far he has not opted to do that. Okay, and the next major story type you could do is kind of a how-to for your readers, how to figure out what they're going to pay if they need to get care. I did this sort of story using the example of figuring out what I was going to pay to deliver my baby. And I I know I use the hospital's disclosure data, but and you want to tell people what tools are out there, but you also want to note the limitations that these tools, the estimates they give are not a guarantee, and you still want to double check so you don't end up with a an unexpected bill. So my story broke it down into three basic steps. One, figure out which providers are in network. It seems intuitive to those of us in the healthcare world, but it might not be to our readers. And if you even if a hospital on sticker price looks cheaper, if it's not in your network and you pay a larger share out of pocket, that you could end up paying much more and getting an unexpected bill. Step two, you want to look at your hospital's posted prices, or use other tools, but to find out what the range of costs are for your insurance plan. But as I noted, you want to double check with your hospital and the insurer. And step three, figure out what your cost sharing is and your out of pocket limit. Most people, they're going to pay a percentage of their hospital bill, 20%, 30%, whatever it may be, up until they reach their out of pocket limit. So depending on how much you've already spent this year, that can give you a very different result. And finally, reminding people to get things in writing so they can fight back if they get an unexpected bill. Though even if you do all these things, sometimes you will get something you don't expect. After I delivered my daughter, I got a bill for about $40. No explanation, no idea what it was for. I had paid up front what I expected to pay, but I was exhausted because I had a newborn, so I paid it, figuring it was worth $40 to me not to have to spend all this time with the hospital figuring out what it was. And then a few days later, I found out I didn't owe $40, again with no explanation. So even if you've tried to do everything right, sometimes you get something unexpected. And the final story type I'm going to discuss is doing comparisons, looking at the transparency data. Ideally, you'll know what you're looking for because these are massive files and it's very easy to get lost in them. But if you don't have a specific idea, you'd want to pick at most a handful of common shoppable procedures to keep it manageable. Cash prices are going to be relatively easy to compare because they're going to be listed pretty much the same way from hospital to hospital. But it's worth noting, if you write about them, that relatively few people pay them. Most people are going to be using some form of insurance. And unfortunately, hospitals can be a bit of a pain in the way they list different insurance plans. It can be difficult to get an apples to apples comparison. Some will just say, this is what United Healthcare pays us for all of its plans. And some will say, well, this is United's HMO plans versus PPO plans. This is United's commercial plan rate. You get the picture. It can be challenging. And also, some studies have suggested that prices are converging, so you might not find as many big outliers now as if you did this a few years ago. But anyway, I know I'm probably using too much time, so it's great that this data is available, but readers need us to help them use it, and we often need the experts to help us use it. So I will pass it on to them.
I just wanted to ask Meg if you could talk just a little bit about your personal experience. Did you think the work that you did was difficult to find the right prices? Was it you know HHS has said they don't even have the bandwidth to do it very well, and you're just one person. I assume you worked mostly alone. Was it hard for one journalist to do it? Is it a big time consuming project?
I mean, it really depends on the size of what you're trying to do. When I w- gave the example of pricing out my own delivery, I was only looking at 3 hospitals because that was all that was in network for my insurance plan. So that was very manageable. I could do that in an afternoon and write it up. Times when I've looked at doing something more comprehensive, looking at across multiple insurance plans, multiple hospitals in the area, that is a big undertaking. That is a heavy lift if you're going to try to do it as a sole journalist.
And anyone trying to do that with multiple hospitals or all hospitals in a state, for example, that would be a huge challenge. Yeah. Well, very good. That was fascinating. Thank you so much. And so we will turn to Patricia Kelmar now, who can talk about the work she's done with journalists and some PIRG, public interest research group interns. Patricia, go right ahead.
Thank you, and thanks everybody for coming today. This is a really important topic. It's a great new consumer tool, really breaking, a lot of walls that had existed before for people to be able to find out what their prices of healthcare were before they actually got the care. So it's not perfect, as Meg pointed out, but it is a really potentially important and powerful tool. And so as a consumer organization that's been around for 50 years, we certainly know the power of price transparency in comparison shopping. And this is one of those tools that we're just delighted to see come to fruition. This came under the Trump administration. I saw a question in the question box about, do we think this will continue? Of course, there's been a lot of activity from the administration. This was a President Trump initiative and put out there. So I would expect they would keep it. I mean, it is very popular to be able to know a price of something before you actually use the service or purchase the item. So we have been working to promote the rule ever since it passed. We've been both trying to improve it and strengthen it so it works better, but also do some watchdogging. We've spent a lot of time working with the public to teach them about how to use the new tools, and also working with lots of reporters like yourselves who are doing their own stories. But I thought today I wanted to share with you, let me make sure I get my slides up here. Just give me a thumbs up if we're all good there on sharing. Good. I wanted to share with you a little bit about how we went about it. Now, Meg gave you the rundown of the rules. So the one thing is for sure, every hospital has to have on their homepage the words price transparency so that they can immediately get to the price transparency tool. And the requirement for the consumer tool, which is the tool we were monitoring and watchdogging, is for the 300 most shoppable services in that hospital, right? So shoppable services are really those that you could actually schedule and be able to plan for. Those prices could either be in a tool where you plug in some information and it gives you the price, or like a downloadable PDF file. And the prices have to be both for the self-pay or cash-paying customers, as well as the particular insurance prices for all the different types of insurance that hospital has a negotiated rate for. So we tested for this first one, but then of course there is the machine readable file for all their services that is also required under the rule. That's more used by researchers or maybe folks like yourself that want to dig in deeper. So what we decided to do was to go we picked 2 cities that we thought were probably representative of, a little bit of different parts of the country, but metropolitan area. We picked Cleveland and Dallas. And we picked one shoppable service. We picked a surgery, a knee surgery, thinking that it would be mostly in the commercial space, right? Hips are more Medicare prices, but knee surgery. And we picked we wanted to look for both the cash prices and the insured price. Now, the thing that we were doing there is really just one, watchdogging. We had been hearing there wasn't, good compliance with putting prices out there. And two, we wanted to see if we could find the prices, what were the price variables, so that our reports would just demonstrate to people the power of the prices if they're actually given in a way that consumers can find them. So I'll just walk you through how we did the Dallas survey. And, this is easily replicable in every community. As Meg said, you can decide how big you want it to be, but I'll just show you how we did it. So we picked the knee surgery. You should be aware that the different tools might have you have a CPT code, or you would use a common name like knee surgery. You want to try to be pretty clear on what you're looking for so that you can compare apples to apples when you're going to the price comparison part of things. Some hospitals use DRG codes, which are diagnostic codes, which aren't really the same thing as the procedure code, which is the CPT code. So you just want to make sure, however you're doing the comparison, that you're noting how the hospital is providing this information to you, what type of code they're using. You should also know if you're going to be testing insured prices, you need somebody's insurance. So it might be your own insurance, or you might get you and your colleagues' insurance if you have different insurance and you wanted to show a few different insured prices. But you'll need that information. You'll need to know whether it's an HMO plan and that kind of thing to be able to get an actual insured price on the tools. Then you need to decide your geography, right? Getting a list of hospitals, and then confirm that the service that you're testing is actually offered in all of those hospitals, right? So you'd eliminate any hospitals that didn't offer the knee surgery, because you don't want to ding them for not giving a price if they don't actually even offer the surgery. And then we always recommend taking screenshots, capturing the links, right? Just for your fact-checking purposes and making sure everything is accurate in your study. So here is the report that we issued in the Dallas area, and this just gives you a sense of the kinds of things that you would maybe have as a finding. So we looked first, is price transparency on the homepage? Almost all of the hospitals were doing that. Good job. Then we were looking for online self-pay prices. We saw a greater compliance there than we did for insured prices. And you can see, not only did we see that only 13 actually had a way to look up an insured price, but 4 of those prices gave us an amount of 0. Now, the insured individuals that we were using, they hadn't had any other expenses that year, so they would have definitely had to pay something. They hadn't hit their maximum deductible yet, or out of pocket. So they definitely would have had to pay something. So that we counted as an unreliable price if it said the knee surgery was going to be 0. Sometimes the tool would pop up and say, especially for insurance, call the hospital if you want to know. Well, that's not in compliance with the law. They're supposed to post the price. If you do want to go through the process of getting the price by calling the hospital, you might want to look at how long you waited on hold, how many calls it took, how many days it took them to call you back, and that kind of thing. And you might, if you wanted to, call every few days and see if you're getting the same price, because we found sometimes it varied by who answered the phone and the price that they gave you. When we did find the prices and compared them, we could see significant savings. And this is a really great finding and really interesting to people, right? To understand, wait, it's, there are really variances. Even as Meg mentioned, there's talk of the prices coming together, but we found even in insured prices in the Dallas area, you could save almost $3,000 depending on the hospital that you picked. And I just note here that there were no physician prices in these Dallas hospitals, although when we looked in the Cleveland area hospitals, many of the Cleveland hospitals listed a physician price as well. So when you're writing your stories, you should tell people, look, you're going to get a hospital bill, and you're also going to get, if it's a surgery, a physician bill, right? So you should understand and know that, and you might want to talk about that, or look if the tool offers physician prices. The other thing to note is facility fees are not disclosed through this tool. So that is another fee that people might end up having to pay, and you want to talk about that. Some states have banned facility fees, but you might need a separate call to the hospital just to see if there would be a facility fee attached to that. So this is just a demonstration of how we showed the compliance of the hospitals in the Dallas area, right? Whether or not they had the CPT code that we were looking for. That may not be as important or relevant to you, but certainly whether we could find an insured price or whether we could find a cash price. And there's like helpful information. People want to see what their local hospitals show. Then we did some charts like this, right? These are the online self-pay. This is the cash price. Now, it's important, even though most people don't use self-pay, that's an important thing for folks to know because sometimes self-pay is less. And so if you don't think you're going to hit your deductible that year, you might just want to pay less money out of pocket if this is just your one thing that you're going to do and it's going to save you money than what the insured price is. It's also something that people can use as a negotiating tool when they're trying to negotiate down prices. If the self-pay price is less and you're being billed so much more, you should use that. You can tell people they can use that as a negotiation. This was, as I mentioned, right, it was harder for us to get insured prices. So we didn't give anybody credit for an insured price at all if we had to call them or it said zero. These were what we could find for an insured online price for that person's insurance for that surgery. So again, you can see the differences in prices there. So I know we're going to get into this more, but I did just want to mention a few things. Like it's a strong first step to giving price transparency, but we obviously need stronger enforcement. We have a few states that have replicated the federal rule into their state laws to give their states power to enforce it. For example, in Texas has given out 11 fines over the last year, and CMS only gave out 3. So having state regulators looking and enforcing is a great way to get better compliance and to get the state kind of more engaged in the value of price transparency. Also, whether employers are able to get this information, that's another way and another angle of a story talking about how employers are going to use it. And I know Kiana will speak more about that. The downside is these are estimates. It's not a real, actual, reliable price but it is something to start with. So again, comparing your bill at the end of the day, telling your readers that they can look at the prices that they got online and compare it to their bill. It's something anyway to start that negotiation and to try to bring down your prices. The downside is the rule only applies to hospitals, but most people aren't going to the hospital. Most people are dealing with imaging centers, lab work, urgent care, right? So it'd be great to see this kind of price transparency in more sites of service. And then when compliance and accuracy improves, we really need to get people using it and we need to give them more tools. Colorado repackaged a lot of this data in a more consumer-friendly tool, and we want to see more of that, right? There should be better scrubbing of data from the hospitals. If we got better uniform online prices from the hospitals, we could have more of these tools that would be able to kind of compile it and make it easier for people to use those prices, and better and easier for employers to build networks. So happy to talk more in the discussion and answer questions, but that's all I had to say for now.
Thank you very much, Patricia. I just wanted to ask a couple questions about what you said. One, Texas is fining hospitals, and that's a great thing. Even if they just said, what did you say, 3 hospitals were fined?
CMS did only 3 and Texas did 11 in the same time period.
That's right. All right. CMS did 3 in Texas, and CMS did 11. Texas did 11. If reporters write about that, in other words, if every time a hospital is fined by the state, someone does a big story, that will lead other hospitals to be, we better get on this because it's a big issue. And if the fines are big enough, hospitals will care, and if the reporting is widespread enough, hospitals will care. And you made a really interesting point about self-pay and how that saves money. The one slide you had showed a range of $170,000 down to $18,000 for one service. Wow. So thank you very much.
So that's, I mean, that's a good question to
Go ahead.
ask, right? So you have to know, like, maybe it includes the physician fee, right? So it's not always super clear, like, why there's that variation, but at least it gets the conversation started, right? And then I would
This is
want
a
to
really
point
good
out,
point you
Joe,
made.
sorry, go ahead.
No, go ahead.
I want to just point out that people can find, at least right now, all the CMS fines that have been issued are online, and you can actually read why they failed in compliance, what the fine amount was, and all of that is available. So, and those 3 hospitals that were fined, that was nationwide, right? Not Texas.
Right,
So CMS
right,
really,
Nathan.
has dropped the ball on enforcement. So I think state regulation is the way to go.
I agree. You made a really good point also about doctor prices. And of course, if you have surgery, you're going to have the doctor bill, the anesthesiologist bill, the hospital bill, and those are all separate bills. And so, if you're looking that stuff up, you probably, I don't know if I've ever seen a doctor price anywhere, and there's multiple doctors you could choose from.
Yes, so people should know that under the No Surprises Act, if you're a cash paying customer, you are allowed and must get in writing a good faith estimate. So anybody who's paying for cash, they can get it in writing from their physician and the hospital what their good faith estimate is. And the patient has the ability, after the bill comes in, if the bill is more than $400 over, they have a dispute system through CMS that they can use to fight that bill.
And you know that because you're on the committee, right? That's working
Right, I served on
to
the committee to get better protections for ground ambulance surprise billing because the No Surprises Act did not cover ambulance transportation. But that's a whole nother
right.
webinar.
That's a right, exactly. Yeah, thank you very much. Um, Kiana, your work with employers is fascinating to me, and so I'd be interested to hear how I'd be interested to hear your presentation. So go right ahead, please.
Great, Joe. Thank you. I'm really excited to be here today because, Meg and Patricia both shared awareness is such a big issue. So this is really the perfect audience to help raise awareness of what's possible, but alongside some of the issues and headwinds that consumers, employers, and purchasers face. We know, sadly, all too well that high and rising hospital prices are really a leading driver of healthcare costs for employers and working families. And negotiated hospital prices have grown faster than prices for prescription drugs, physicians, and even college tuition. And we see all too often that patients are being pushed into catastrophic medical debt due to outrageous and indefensible hospital prices. So you heard from both Meg and Patricia about some of the great work they're doing that helps consumers. I'd also like to shout out Consumer Checkbook, who's also doing some great work to help consumers shop and tracing the customer journey to uncover really overlooked administrative friction. The work that I'm going to talk about, as Joe mentioned, is work with the National Alliance of Healthcare Purchasers Coalitions to help educate employers, healthcare purchasers, and policymakers with this data. So I'm really excited to show 2 free and publicly available tools. I'm going to share my screen just for a second. Can you all see my screen? Perfect. Okay, so the first tool is called Sage Transparency, and that's an online dashboard that was created by the Employers Forum of Indiana. It brings together both public and some proprietary quality data that allows you to compare hospital prices and quality across hospital systems, across states, and nationally. The second tool that I want to highlight is the NASHP, that's the National Academy of State Health Policy, their hospital cost tool. We don't have time to demo both tools today, so I will dig into the SAGE tool, but before we go, I want to show you just briefly what you can do with NASHP. One thing I want to mention is the NASHP tool. It's both a tool, but they also have the data available. So you can download the data. And what you see here is just a very basic Tableau dashboard that I put together using the NASHP data, as well as the, again, also publicly available CMS hospital quality rating data. And so you can compare hospitals, again, nationally within a specific geographic region or within a state for their cost and quality. So what you see here is across the top, you'll see the hospital rating. So this is a 4-star rated hospital overall rating, all the way down to a 2. Sorry about that. There are 2 key metrics here that I want to highlight. There is the total facility fee. This is calculated or represents data that RAND calculated from a study that they did. And what they did was collect data from health plans. So this represents commercial claims that were paid. So this blue line, again, represents essentially what commercial payers paid that hospital. This green line that you see here, this is the commercial break even, and this is a NASHB calculated metric. This essentially says this is the payment rate that commercial payers should pay hospitals in order for that hospital to break even. Now, obviously, we know hospitals should make a profit on top of commercial payers, but what we're seeing here is just astronomical numbers, right? So this 517% is a percentage of Medicare. This is what commercial payers were paying. And then the 225% is essentially what commercial payers, the hospital should charge commercial payers in order to break even. And that's a huge delta, 255% to 500%. But commercial payers are overpaying hospitals. And one thing that I wanted to note is this green bar that takes into account what hospitals might be losing on their Medicare, on Medicaid payers, and also it takes into account what they've paid for charity care. One thing that I would like to highlight before moving on quickly is, and you'll see this in the demo that I show, is that quality is not correlated with cost. So sometimes you think in other markets, you may pay more for better quality. Well, we don't see that here. We see some of the 2-star hospitals charging more than what you see a 3-star hospital charging. And then one thing before I jump over to the demo, the NASHB, again, they have a tool, but what I like is their data, and it's extensive. It also has data dating back to 2011, so you can see historical trends over time. One other thing I'm going to point out is profit margins. You can see this blue line here represents the commercial operating profit margin. So that's the profit margin that they made on just their commercial book of business. Again, obviously they see Medicare patients, they see Medicaid patients, but I mean, again, it's astronomical numbers. Oftentimes you'll hear hospitals share that they're losing money. And again, sometimes they are. Again, you can see a hospital here that's losing on their net profit margin. But one thing I want to point out that you can uncover in these tools is there's a net profit margin. Sometimes that takes into account what they've lost on investments or things like that. And we shouldn't have to pay for that. So that's one thing I want to highlight. This operating margin is really the margin that they're making on patient services here. So again, we're seeing really, really hefty margins, but we often hear something different. Okay, I am going to jump over to the demo. And I really want to make sure we leave some time for questions. Are you all able to see my screen? Perfect. Okay, so there are a number of tabs here. I will drop these links in the chat as soon as I am done speaking and when we get to Q&A, just so you have them handy. But I'm going to start with the state compare tab here. And if you scroll down, you can see again, I talked to you before about that commercial, the total facility fee. Which is the RAND price. So again, that's using commercial claims. You can see how your state compares to others. We see, sadly, that Florida is leading, but you can see each state and how it compares to the national median. I'm going to jump over and show you 2 other tabs. Again, we don't have time to go through all of them. One thing I'll note is a lot of the tabs, information is the same across tabs. It's just different ways to view the information. There is a hospital systems tab, so you can see all systems across various states. But again, for the sake of time, I'll drop over to the hospital by state tab. You can see the hospitals within a particular state. So the drop down, you can select a state. It was built in Indiana, so it defaults to Indiana, but you can select whatever state or region you want. You can also select down to specific hospitals. I want to show you briefly on the tab, this chart to the right. Sorry, it's a little small here, but you can see a chart. This chart here shows the CMS star rating across the bottom and then the cost. So these hospitals that are highlighted in red, these are the low quality, high cost hospitals. And I think Meg talked about briefly being able to steer or avoid. You really want to avoid these hospitals. The ones in the green, they are the more highly rated hospitals, but they have the lower costs. So again, this is a great tool for being able to make some of those comparisons. As we go down, I'm going to just go ahead and filter out to one hospital system to make the charts easier to read. So you can see here, again, similar to the chart that I showed you on the tab, that used the NASHB data. This is the SAGE data. You can look at what those comparisons are across various hospitals. One thing I'd like to note is they have a really great feature this year where you can export tabs. You can create a PDF and you can pull the charts and use them however you'd like. I'm going to pop over to the legislator tab. And again, as I mentioned, it's very similar. Pick a state, we're on Indiana. You can pull this information for either your state or your US congressional representative. So let's say you pick the state, it'll pull up the state legislators in that state, and you can select someone, and that'll show you all the hospitals within that person's legislative district. And so again, this is really, really helpful from a policy perspective, or again, just being able to draw attention. As I mentioned, I will show you what the report looks like because I downloaded it briefly. So again, it'll produce a nice like one-page report letting you know where your state ranks. It also lists the hospitals, both the quality rating as well as the hospital price. And then you can also see the chart that I showed you there before. I know this was a lot, and I condensed it in quite a bit of, or I condensed it a lot. I will drop my email in the chat. I enjoy talking about this stuff. And again, I really appreciate the awareness that you all will bring to it. So Joe, I'll pass it back over to you.
Well, thank you very much, Kiana. Yes, it was a lot, and I was taking notes as fast as I could. One of your slides, slide 3 of 4, in the before you got to the NASHB, I mean the SAGE tool, talked about the commercial break even, and I wonder about that. Like, is that something reporters could ask hospitals about? Like, you could see that one hospital, their break even was just astronomical, off the charts. Like, why are they charging so much when everyone's struggling to pay hospital bills, and hospital bills are already really hard? I don't know if that's it. Yeah, I think that's it. I forget the hospital now, but it was just huge. And
Yes.
should journalists call hospitals and say, once they have that data in front of them, say, the tools from the National Association of State Health Policy show that your prices are really high and harming employers. When journalists do stories about how high hospital costs are, they also, at least recently in Indiana, they talked to employers in the Fort Wayne area, and the employers were saying, we can't afford these price increases year after year, and a lot of employers say the same thing. So is that a question that the journalists should be asking employers or asking hospitals? What do you think?
That's absolutely a question that they should ask. And again, especially when you see these astronomical costs for low quality hospitals as well. So they should. And often, again, I mentioned working with employers. We have employers that will do just that, reach out to hospitals and have those conversations. And sadly, because of so much market consolidation, that the hospitals are often tell them, well, we charge you that because we can. And the employers often sadly don't have enough bargaining power. So again, any attention that we can bring to this from a journalistic perspective would be absolutely helpful, because again, the hospitals are charging it because they can.
And that's the actual reason. They can charge it because they can, and no one is holding them accountable. And maybe it's about time. I mean, I don't know who else is going to do it if employers, because they're so fragmented. There's maybe a big one in your city or town, but most of them are small or medium size, and so they don't have a lot of clout, a negotiating clout.
Yeah,
You
that's
also
exactly
mentioned,
right.
yeah, then that's their problem, right? They don't have the negotiating clout. Plus, they don't have a lot of them don't have the skill to know that they may not have the information that you have, for example. If they don't have that, then they're kind of arguing in the dark. You also mentioned that legislative districts, Congress people, could journalists go to members of Congress and say, these hospitals in your district are charging whatever they're charging? Wouldn't the congressman just say, or the congresswoman say, that's a local thing. I'm willing to, you know, I mean, what can a Congress member do, I guess is my question.
Well, I think, we find when we share this, it really gets their attention because it's their constituents that bear the brunt of
Mm.
this. Again, it impacts wages. We are seeing, again, rising medical debt for consumers. So no one can afford to bear these prices. Employers are not able to either reinvest in their employees or in innovation. And so it's a huge issue. So I found that Congress people really do care about this. So bringing it to their attention is really helpful. And I think it's why the folks at Indiana added the legislator tab, because it makes it so much easy to print the one pager and be able to share that information. So I would encourage folks to do that.
The folks in Indiana being Gloria Sashdev
Yes.
before she was named to be the Secretary of Health and Human Services in Indiana. She moved from the Employers Forum of Indiana, the coalition, the very impactful coalition there in Indiana, to the state office of HHS, which will be fascinating to watch, I think, in my opinion.
Absolutely. One other thing I'll drop in the chat, again, given the work that we've done with national coalitions across the country, we put together a case study document to highlight some of the issues and push back some of the policy issues we've seen across various states, but also some of the great work that employers and purchasers have done. Many of the coalitions have also put together reports. And so there's some really interesting findings that I think reporters can find out of that. And a fair amount of the work has been already done for them. So there's some really interesting, I think, nuggets that they'll find in that case study document.
Oh, that'd be great. Thank you very much. And employer coalitions are in almost every state, right?
We have a fair number of them, yes, in
And some
most.
of them are really, really good. Like the one in Colorado, Meg, is supposed to be very, very proactive and doing a lot of good work. Indiana, of course, is very good. Some other states have really good ones. So that's a source for journalists, is to go to employer coalitions. So we have some questions from some of our members. The first one is our member Nick Stonecipher wants to know if hospitals can be fined by the federal government. Can state AGs also fine hospitals? And is it consistent across the board, or is it different in every state? And any of you know Patricia, Meg, or Kiana?
Yeah, I think, the rule doesn't specifically give states the ability to enforce it, right? Under the No Surprises Act, they did let the states decide if they wanted to enforce the No Surprises Act and surprise billing. But in this rule, it didn't specifically say that. So I think you would need either the Attorney General doing something like, it's deceptive, or using like kind of Deceptive Practices Act as the tool to do state enforcement, or you would need something like Texas did, which is actually passing your own state law that mimics the federal law, and then using that state enforcement power through that law.
And that law is brand new in Texas, right, Patricia?
It's a couple of years old, I think now, but they're
Oh,
always making it better. Yeah, because they just started fining last year, so the law's been in effect for maybe 2 years or so.
see, and it would be that would be something the National Association of State Health for State Health Policy might track, right?
Yes.
So
Hmm.
so we could go there and check with them. Another question comes from Leiden Marcelot. Any new information on efforts to standardize formatting of the machine readable data sets? Many people are saying you need a supercomputer to process the multiple nested file structures. That's a really tough question. What do you think about that? Do you want to take that one,
I'll
Patricia?
try, and then if anybody has more.
Yeah.
Every year CMS kind of puts out a chunk of rules, a big giant rule where they're updating and tweaking existing rules and regulations. And there's always efforts and comments from consumer groups and researchers and everyone to make it more consistent, to make the way that hospitals issue those prices and post those prices better and better searchable. It's my understanding that they didn't really make any changes in this past iteration. They did over a few previous years, but the last year's new set of big rules didn't really make any changes. So there's still more to be done. I don't know if Kiana wants to speak to like what else, or Meg, maybe you know better.
Yeah.
I wouldn't know a lot about CMS. I would say though, there is something to the criticism about these are not the easiest to work with if you don't have a lot of computer skills. At least in Colorado, most of them are using JSON files, which if you don't know how to code is pretty much useless to you. So
Yeah, I think that's
JSON is
right.
JSON. Can you? I'm sorry, Kian. I just wanted to ask. Could you explain that acronym, Meg, please? JSON.
I
JSON.
have no idea what it stands for, to be honest. Just that it's
Okay.
yeah, sorry.
Oh no, that's all right. I'll look it up.
All I
Thank you
know
very
is
much.
it's really hard on a regular computer to work with JSON files. It's not like an Excel spreadsheet.
Okay.
And think about when I've heard researchers working with those files. The Blue Cross Blue Shield Gold HMO plan could be abbreviated in some wackadoodle way in one hospital, but another way in another hospital. So measuring apples to apples doesn't really work very well. So we really need a more consistent way.
Yeah. Okay. Kiana, did you want to answer that question?
I was going to add, it looks like someone put in the chat what JSON stood for. And it is,
Oh, thank you.
it's overly complicated. Again, I would say there are folks out there that are pushing to work on CMS to actually have them make some updates to it to make it more streamlined. As Patricia said, there's been some work done. There's a lot more to be done. We see often in the files that there's a lot of repetitive information and it's not consistent. And so there's, again, work to be done to make it more streamlined. Consumer Checkbook has been, I think, putting out some work on some ideas and suggestions to CMS on how to do that through maybe like a network ID, for example, so that oftentimes the information is unnecessarily repeated, and that leads to the files being issues with the data, so quality of the data, but also in the files being larger than they really need to be. So maybe more to come on
Thank you
that.
very much. That leads us very nicely, Kiana, into the next question, which is from Katie Galvala. Hope I'm saying her name correctly. How should reporters think about the reliability of quality measures? I've read that different rating systems, Leapfrog, CMS, can often show very different ratings. Is it more reliable to stick with specific measures, such as the prevalence of C. diff infections at a hospital, for example?
I'm sure there are
Who wants
different
to take
thoughts
that
on
one?
this.
Go ahead.
Mine are, I mean, again, I think having the information that it varies, but when you make that comparison, so again, looking within Leapfrog and comparing hospital to hospitals, they're compared consistently sort of within the, Leapfrog system. So that's a way to measure hospitals within, the Leapfrog system. I would also suggest looking at the CMS star ratings as well. And then again, comparing hospitals to hospitals within that system, and then looking for trends across the two.
Okay.
And
Question for
people
you,
should
Kiana.
remember
Could you
that
show
there
the
are,
slide?
sorry,
I'm sorry. Go ahead,
there are
Patricia. Go
some
ahead.
states that do their own state reporting of infections and things like that. There was a big movement about 15 years ago to get states to do that. So don't forget that there might be some data there. It would be good to watchdog that. Are they still putting out those reports? Is there a way that they can make them more consumer friendly now that we have greater tools? So we have a long way to go on quality. I'd be happy to talk more to whoever's interested in that. I have some thoughts as well.
And
Thank you very much. Go ahead, Meg.
one tip on quality I'm borrowing from another webinar actually was that one way to get around some of the limitations and the questions of, which places are looking harder for their C. diff infections would be to focus on things that should never happen. Like,
Never events.
they are required to report when they operate on the wrong side of a patient, or, leave a sponge inside someone. So that's one way of looking at quality, but every way you look at it is going to have its limitations.
That's a good point. Another question for you, Kiana. Could you show the slide where you showed prices unrelated to CMS star ratings? Leiden Marcelot said that was a very impactful slide. If you can take a minute to dig that up. So one more question. I don't know who can take this, but Liz Seegert, my colleague, said, how do these rules apply to Medicare and Medicaid beneficiaries, if at all? Could anyone address that one? Do you all think about that while Kiana gives us the answer to the previous question about how hospital prices are not related to quality?
The Medicaid and Medicare prices are set, right? So there's just one price. So these price transparency rules are not not part of that. They don't talk to those payers. This is really a self-pay and commercial insured tool.
And people who have employer-sponsored insurance would shop. Yeah. Kiana, did you want to answer that question about your slide on?
Sure. Yep. I pulled it back up, and happy to share the slides with you, Joe, to share. These are, again, just examples pulled from the specific data, but I think there's been a lot of research. And again, we see it in the data that just because a hospital is charging more than other hospitals doesn't mean their quality scores are higher. And again, we see that with CMS data, we see it with Leapfrog data, and we see it consistently across quality measures. So oftentimes people would think, well, if I pay more, I'm going to get more features, or I'm going to get, a higher benefit, and that's not the case. So that's just a point I was making.
Yeah, not related. So Liz corrected me. It's not Medicare and Medicaid, it's Medicare and Medicare Advantage. So Medicare Advantage patients might shop if they had a Medicare Advantage plan that required them to pay a deductible, for example. Is that right?
I'm not sure if the Medicare prices are there. I mean, the issue with Medicare Advantage is, there's some cost sharing there, and the price makes a difference for their cost share. So I'm not an expert on that.
Yeah, it's tricky. It's tricky. Cost sharing is tricky. One last question from Elijah De Castro. I'm going to ask you all to predict the future a little bit. As AI gets more integrated into healthcare, how is it, or will it be, to use to determine prices, particularly for hospital prices? Any idea about that?
Well,
I have
I'll
no
just
idea, so I'm
add that
glad
the
I'm asking
underlying
you.
data has to be of high quality, and it has to be accurate, right? Because any predictions that comes from that, if it's not accurate, it's going to be false.
Great answer. Thank you.
And AI
Well, thank
might
you all
work both ways.
I'm sorry, Patricia, go ahead.
Yeah,
Go
I was
ahead.
just going to say AI could work both ways, right? Like we could get better at, if the data is good, we could get better at scrubbing it and using it and having it more consumer friendly, right? And even like if you're just screenshotting a bunch of prices today and then go back in 6 months, you know, in another 6 months and check the prices, like you could even be doing your own analysis of like how much prices have gone up in the last 6 months in your community, right? So that's another way to use AI, right? Like we need to be using it for good things, is and but yes, be aware of all the dangers within AI.
That's a really good answer. So I just want to wrap up by announcing that next week, my colleague Karen Blum, who covers health IT, will host a webinar Wednesday, February 5th at 1 p.m. Eastern Time on telehealth. The title is Telehealth on the Line, What Could Happen This Spring. So be sure to mark your calendar for that. And thank you very, very much, Patricia, Meg, Kiana. What a great webinar. Thank you so much for all the great comments, story ideas, and data you brought to this panel. It was really terrific. It's a pleasure to work with you.
Here.
For having us.
Thank you for the opportunity.